Mhm. Hi, Divya, can you hear me? Hello, Divya. Divya? Come in, Divya. Hello, Divya or Michael.
Hi, are you guys able to hear me?
How you doing? Oh no, I'm trying to get Divya there. Your name looks familiar, Michael. You're one of the speakers today, right?
Good morning. Are you able to hear me, John?
Good morning. Yes.
How are you?
Okay. Is this Michael?
That's me.
Yeah. How you doing?
Good, good.
You got your picture on your profile?
Um,
You got to enable it. It's at the bottom left. There you
can you
go.
see me?
Yeah, there you
Okay.
go.
Yep.
You look like at a ski lodge.
I am visiting my family in the Canadian Rockies right now. So,
I know you got to go where you have to go.
yeah, that's right. So it's quite early in the morning here.
Well, it's good you're creative and you got a spot, or is that their usual spot for the internet?
This is just where I happen to be that I'm least likely to wake up the rest of the family at 2:30 in the morning. So,
Yeah, right. Where are you at?
I'm in Banff, Canada.
Oh, wow. Wow. Gorgeous place. I spent the best time of my life in British Columbia in Vancouver.
Yeah.
Oh, I loved it there.
Yeah.
It's I know you're not going to have time to travel around, but that whole area of the world is fantastic.
Oh yeah, for sure.
But you a skier? Is that why you're in Banff?
No, my in-laws are from here.
Oh, okay.
So
That's good to have family in a place like Banff.
yeah, it is. It is.
Okay. Let's see. Dibby was, excuse me for a minute. I'm going to look for Dibby.
Okay. Yeah, I'm
Yeah, yeah, we don't start for 25 minutes, Michael. We don't start for
just
25 minutes.
great. Sounds good. I'm just gonna mute myself until we're ready.
Sure. All right, Divya,
Hello.
how you
Hello.
doing?
Hi. Hi. I opened that link over the mail, and I'm just trying to log in.
Okay, let me see here.
Showing open Zoom meetings. That's the one, right? Launch meeting. It's showing.
Yeah, you've never done a link, you've never done a Zoom before? Okay, are you in
I've
the,
logged in through the
okay, you gotta click on the link that's everywhere on the internet. Let me give it
on
to
the
you.
mail on the.
Yeah,
Okay. Okay.
okay, let me get the, hold on. Can you come into the Zoom now? I can't,
I'm on this Zoom workplace.
okay. Oh, no, you gotta come into the Zoom. Oh, hold on. I'm gonna send you the link on your WhatsApp, okay?
Okay.
And you tell me if you get it. You got it? Oh, you're here.
Finally got in.
Well, Divya, I was scared because I thought maybe you started another Zoom.
No.
That
Yeah,
happens sometimes. Sometimes people
happens.
misunderstand
Yeah.
and
Yeah.
they think I'm doing a Zoom and they can do a Zoom on their own, but that you can't do that.
Okay. Okay.
So anyway,
Just I think Dr. Kishore is trying to log in. I'll just ask him. Is there any problem with him? I just come back.
no, everything looks okay so far. Okay, everybody's in. Well, and do you have any questions about Zoom? You've done Zoom before, right, Divya? Okay. Yeah.
Hello.
Yes, Divya.
Uh, uh, Hello.
Yes, yes, yes.
Uh, I've sent you a mail. You have to send the link to him. Dr. Kishore is waiting. He's not able to get in.
Yeah, I know how to do Zoom, Divya. Okay, I got it. I got it. Okay, Divya, Divya, you can talk to me, you're in the webcast. You don't have, I don't mind getting contacted by WhatsApp. but
Yes,
you
yes,
can just
I
chat with
am.
me here. Yeah, you do.
Okay,
Divya, they used to have a co-host feature on Zoom, but they took it away. So, yeah. So I do appreciate if you tell me, hey, somebody needs to come in.
okay. I think all the speakers have been made the panelists. They've already joined in,
Oh, good.
and yeah, Dr. Atta
And
is also
and
here.
and Atos came here at the last minute. Maybe just hello, Ata.
Ah, yes. Okay.
How you doing, Ata?
I think it just
Yeah,
landed.
I'm fine. I'm at airport. I just landed in Geneva.
Just landed. Yeah.
Well, we appreciate you connecting. Okay, 4 minutes, Divya.
Yeah, yeah, sure.
Hi, Dr. Dubia. Am I audible?
Good day.
Oh, hi, hi,
Please,
Dr. Arun.
all the panelists, please put your picture on. This is not meant to be an anonymous affair. This
Hello, hello, John.
Hey, good day. How are you, Dr. John?
I'm good. I'm good.
Nice to meet you.
Hi, Mike. Hello, Dr. Lang. How are you?
So nice to see you guys. How are you?
Welcome, everybody.
We are all
Good.
fine. Fine. Just we'll start off in a couple of minutes. Let me
Here,
make
what
couple of
I'll
notes.
do,
I'll make
the way, Divya, the way I prefer to run it is that I'm going to introduce Atta first, and he's going to introduce you. Is that okay?
Yeah, yeah, sure. No issues.
And then you basically run it from there. You
Yeah,
coordinate the speakers and coordinate the Q&A if you have Q&A, whatever you want to do. And
okay,
you run the show after that.
okay, fine.
Okay. Okay, Yata, can you do that? Hello, Atta? Well, maybe I shouldn't depend on Atta, I don't think. Uh, From Delhi, India, right, Divya? Yeah, I'm going to introduce you.
Have you sent that mail to Dr. Kishore?
Is he trying to get in?
Yeah, he's trying to get in.
Don't have a Fisher.
Um,
Have a Brian Gervais, Pranav.
no. You have sent the mail, the link, right?
Who?
On mail to Dr. Kishore Chaudhary.
Well, the link is
I've
on the
sent.
website.
I have actually sent you a message on WhatsApp. There's a, mail ID over there. You need to send the link that you had sent me.
Okay, and what's up? You sent a message? Oh, God. Oh, okay. Oh, yeah, I got the email. Okay, I just sent him the link. We can wait a few minutes.
I think he's not able to join in, I guess. Just a couple of minutes. Once he joins, we'll start.
Yeah, can you see the panelists from your screen?
I can see just one name is missing.
Who's waiting?
Dr. Kishore.
Is
Dr.
anybody,
Kishore Choudhury.
Dr. Fisher?
Yes, yes.
I don't see a Fisher. You can see it right too. Bashir Ahmed, Eric M.
I'm just trying to contact him.
Okay, we can start. Is he the first presenter?
Uh, okay.
He can not come later, right? We could.
Okay, fine. We can do
Yeah,
that.
okay, Atta, you there, Atta? Atta, it sounds like it's too difficult for him to coordinate it, so I'll
Yeah,
introduce.
just a minute.
Yeah, okay, I'll just wait a minute. Go
Okay.
ahead.
He's just trying to.
Okay. We can wait a couple minutes if you want.
He's just joining. He just has to register first. Just joining in 1 minute. You can just start. Just hold on for just 1 minute.
Sure. Hello, Atta. Yeah, he's not able to introduce you. He's in the middle of this busy airport. He's probably Atta. It's no big deal.
Yes, John.
It's no big deal. Yeah, I'll introduce him, okay? It looks like you're in a bad spot. Okay?
Okay.
Yeah. We're just waiting for someone. Well, if he hasn't come in after sending the link,
I don't know.
I think we better start, Divya.
So, shall we start?
Yeah, okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett, home of Neurosurgical TV. We have the honor of having Divya Joytil, a neurosurgeon from Delhi, India, that has a group alliance of comprehensive neurovascular surgeons, and I was lucky he contacted me to network, and it just so happens I became affiliated with Atta Bhatti. He's also a dual neurosurgeon, and we welcome the collaboration. And from this point, I'm going to let Dayudi kind of run the show, and he can do what he likes. Welcome, Dayudi.
Okay. Hello. Good morning, good afternoon, good evening to everyone who has joined from whichever part of the world. Myself, Dr. Divya Jyoti. I'm consultant minimal invasive neurosurgery and endovascular neurosurgery at Yasoda Medicity, Delhi. So I'll be taking you through this today's session. I welcome you all to the second webcast of ACONS, that's Alliance of Comprehensive Neurovascular Surgeons. It's a series of webinars that we have planned to bring together comprehensive neurovascular surgeons all across the world to share their thoughts, their philosophies, and to guide and inspire the younger lot to take up cerebrovascular surgery by passion. On the other side, by being hybrid in our approaches, we shall have that extra freedom in choosing the right sort of treatment plan for our patients. This unbiased approach towards patient care is possible only when a neurovascular surgeon is equally trained in both open and endovascular approaches. And to guide us through today's session, we have some eminent people from different parts of the globe. First of all, Dr. Anita Jagatia, she is the head of Department of Neurosurgery at GB Pant Institute of Postgraduate Medical Education and Research, Delhi. She has been the force behind this concept. Unfortunately, right now she is stuck in a case. She'll be joining later. Then we're joined by another passionate hybrid cerebrovascular surgeon from Geneva, Switzerland, Dr. Ataul Alim Bhatti. He is also the president and CEO of Neuro Healthcare for low medium income countries, and has been passionately working to bring the quality neurosurgical care to the people in low medium income countries. We also have with us, welcome, Dr. Alim. I think he's stuck in the airport, I guess. So we have another chairperson, panelist over here, Dr. Kishore Chaudhary, sir, another prominent figure in cerebrovascular surgery. He's a consultant neurosurgeon at Sheffield Teaching Hospital, UK, and is also the director of cerebrovascular fellowship program over there, and has trained hundreds of neurovascular surgeons across globe. But has he joined yet? Yes, I think yes. Welcome to you, sir. Kishore Chaudhary, sir. Okay, moving with our first speaker. It's a great pleasure to introduce today's first speaker, Dr. Michael Lang, a comprehensive neurovascular surgeon and director of cerebrovascular neurosurgery program at University of Pittsburgh. He specializes in treating complex vascular pathologies using both minimally invasive and open surgical techniques. He also holds subspecialty training in functional epilepsy surgery and with advanced fellowship experience from Barrow Neurological Institute. A widely published researcher and international speaker, Dr. Lang focuses on surgical outcomes and multiple innovative procedures such as MI-compatible robotics. We are honored to have him with us today to share his expertise. Welcome, Dr. Lang. The screen is yours now.
Wonderful. DJ, thank you so much for having me. I'm delighted to be here. It's quite early in the morning. I'm actually out in the Canadian Rockies right now visiting family, and so you'll pardon me if I'm a little quieter in my delivery. I'm trying not to wake up a whole household full of people right now. But let me share my screen. All right. Are you guys able to see?
Yes,
Yes.
perfect.
Wonderful. Okay. Well, this is a real pleasure for me. This is, one of my favorite topics in neurosurgery is being able to move beyond this idea of open versus endovascular surgery and how we can bring those two fields together to create new and better treatments, but also really be able to choose selectively for particular patients how best to approach a particular aneurysm or disease state more generally. So for me, I've always hated the term hybrid, right? It's been used pejoratively by both the endovascular community as well as the microsurgical community to imply that it is a mix maybe between two purebred lines. The image at the left shows Gregor Mendel and the origin of Mendelian genetics, and that term in the F1 generation shows us that while the hybrid has characteristics of both its parents, it's neither fully either one. Whereas I think the Hegelian model of the dialectic, wherein the thesis and antithesis come together to create something new, is where I see this idea of comprehensive neurosurgery. And so for our practice, find that the choice of a given operation always follows an understanding of the natural history. So, we'll discuss a number of cases during this talk today. But first and foremost, we always want to think about what is the natural history of the disease, and does it even need to be treated at all? Not every aneurysm we see needs to be treated. And, obviously to a neurosurgical audience, I will advocate here my belief that that for those of us that do supravascular neurosurgery and in contemporary medicine, that we really should aim to do both microsurgery and endovascular at a very high level. But I think this idea can be utilized as a team-based approach as well. But it really requires people understanding the entirety of both subspecialties in order to achieve the benefits that we'll talk about. And then last but not least, remember that the patient comes first, not the surgeon. These procedures are technically exciting and provide a tremendous amount of personal satisfaction. But what happens first and foremost is to the patient. So we're all pretty well aware microsurgery has long been our gold standard in treating cerebrovascular disease, and generally speaking is a durable solution to most aneurysms. We have good outcome data over many decades. We understand what these procedures bring to the table. That said, there's also pressure to change in the wake of the development of endovascular treatments, beginning first with GDC coils and evolving through flow diversion intrasaccular treatment to where we are today. Endovascular approaches utilize minimal access. I never use the term minimally invasive because I think that it fails to sell the fact that whether dealing with microsurgery or endovascular treatment, it's still brain surgery. But it is true that accessing the vascular tree through the inside of the blood vessel from a radial femoral approach is overall less damaging than craniotomy. At least up front. The technologies are rapidly evolving, and often this can present benefits in terms of how quickly our field has changed. But the real challenge there is that those technologies are often developing faster than our ability to understand them. But it's all brain surgery. No matter how we deal with it, microsurgically or endovascularly, we're all doing brain surgery. And so when I was in training, this is kind of the landscape that I found myself in, that there were certain things that we dealt with purely microsurgically. Those would include, overwhelmingly spinal dural AV fistulas, bypass or moya, most MCA aneurysms. Endovascularly, a number of things that we almost always did using those techniques, and some things that really overlapped, and from patient to patient, we would deal with one way or the other. But my goal was to bring that Venn diagram into complete overlap so that I always felt comfortable using either set of tools for any given pathology so that I could base that decision on the patient, their clinical status, medical comorbidities, the unique features of the anatomy. There wasn't anything that I felt uncomfortable dealing with. And so that's where I've come to talk a lot about this idea of comprehensive treatment. And so I think it's important to have all the tools and be able to use them. I think it's very important to be able to think fourth dimensionally. Our goals in a particular aneurysm change over time. So what we want in the ruptured setting is very different than what we want in long-term follow-up. We are more willing to tolerate brain manipulation to achieve, complete long-term occlusion. And combined approaches are one of the most exciting tool sets that I can think of today, and can often provide outcomes that neither pure endovascular or pure open techniques can provide by themselves. But as I'll come back to over and over again, being a good doctor comes first. At the end of the day, we have to love treating the disease and not love the procedure. So for me, my microsurgical toolkit and my endovascular toolkit are as my right and left hands. And so I like to be able to operate ambidextrously. And so using both sets of tools, I think is very critical. So certain cases are very obvious. This is a 64-year-old patient who's a Hunt-Hess grade 4 subarachnoid hemorrhage who has this irregular posterior communicating artery aneurysm. So older patient, dense subarachnoid hemorrhage. Now, could this aneurysm be clipped? Obviously, we've done so safely for years and years. But in my hands, I think this is very clearly an endovascular case. This is somebody that we approached from a transradial approach. We used a balloon-assisted coiling technique, got a Ramon 1 complete occlusion, and the patient ended up doing very well long-term. So that, in my mind, is not a terribly difficult decision to make. Same thing is true for when we approach patients with multiple aneurysms. This is a 59-year-old who has this irregular MCA aneurysm that we see in the top left panel, as well as this very small but irregular anterior communicating artery aneurysm. So we approach both of these from a mini pterional approach, which is now the workhorse approach for me. This is a little bit zoomed in, but this is about a 3 centimeter incision just at the lateral border of the hairline, centered over the sylvian fissure. And this is how I approach most supratentorial aneurysms, including some posterior circulation aneurysms. This is another patient, modified fissure 1 subarachnoid hemorrhage with this wide neck basilar apex aneurysm that we did with a Y stent coiling approach. And again, this is a pretty well-established technique at this point, and somebody that we can treat very safely. Again, is it possible to clip this aneurysm if we had to? Absolutely, but the risk profile associated with basilar apex perforator manipulation means that in the overwhelming majority of cases, I think these are best treated endovascularly. But we can also use microsurgery to push the envelope, treating aneurysms that we might not think of, or at least in ways that we might not think of doing it. So this is a patient that has bilateral MCA bifurcation aneurysms. You can see this smaller one on the left, superiorly projecting up between the two M2s. And so here you'll see that I like to make use of sharp microscissors dissection technique, do the entire sylvian fissure split with microscissors alone. And so we're going to work from deep to proximal in this aneurysm. So we reach all the way across the sylvian fissure here, across the anterior communicating artery complex. Here's the ipsilateral MCA aneurysm first, and then we'll work on the deep side. Here we can see the superiorly projecting left MCA aneurysm rising in our field. We actually have complete control of this, and we're using a reverse picket fence construct here, overstacking a pair of fenestrated aneurysm clips around that superior division M2. And then we'll work our way back superficially. ICG here shows us the deep aneurysm. And then superficially, we take care of the more complicated ipsilateral aneurysm using a stacked multi-clip construct to reconstruct the MC bifurcation. And so by doing this, we're able to spare the patient a second operation, deal with both aneurysms contemporaneously. And here you can see the clip heads having approached the left aneurysm from the opposite side of the head. And we've done that through, in this case, a standard pterional approach, but the mini pterional is also effective for this contralateral clipping approach as well. Now, we're going to get in towards some more complicated aneurysms now. So this is a 59-year-old with this nearly giant A2-3 junction aneurysm that's partially thrombotic and partially calcified. You can see from the CTA here. And what I want everybody on the call to notice is the outflow. Here we can see that the bifurcation in the pericallosal and callosal marginal divisions is right at the outflow of the aneurysm, and really is 180 degrees from the outflow here. Now, while it would be possible to flow divert this aneurysm, that's a telescoping construct of multiple flow diverters, requires jailing of the callosal marginal division, and through this very tight turn, that becomes very difficult to open. Not impossible, but that's certainly a very challenging procedure. And then accessing the entirety of this aneurysm into the subgenicular recess requires extensive dissection manipulation of both cingulate gyri, and is not a simple approach by any means. But in this case, what we did was combine two smaller approaches. So small bicoronal craniotomy to create an A3 bypass, which we can do with the head in the lateral position. The patient was then taken immediately to the angiography suite, and we coiled off the entire aneurysmal segment. We can see that our coils come up to the bifurcation in the ACA segment. We can see the A3 bypass here. And the follow-up at 6 months shows that the aneurysm is completely gone. The bypass retrograde opacifies the contralateral ACA. We can also use microsurgery and endovascular surgery to treat the same aneurysm in two different ways, depending on the clinical situation. This was a 69-year-old who had this large hypophyseal aneurysm, PCOM aneurysm that was multiply coiled and restented, and eventually came under my care some years later with this enlarging recurrence at the base. We ended up treating with this flow diverting stent for long-term permanent occlusion. It's a very effective tool. The same aneurysm, however, in this patient was originally coiled and then eventually stent coiled with multiple recurrences, is associated with a fetal communicating artery. And unfortunately, here you can see that the Atlas stent construct lands in the fetal PCOM and then back into the parent ICA. This aneurysm then becomes very difficult, just from a technical perspective, to treat with a flow diverter as it's recurred, but also become ineffective because of the true fetal configuration here. So we can dissect out the neck of this aneurysm. We can see the coil mass being detethered from the frontal and temporal lobes. And after we freely dissected the anterior carotid artery, oh, sorry, this video is a little spotty. We're able to completely clip reconstruct that aneurysm. And here you've seen, this is the view we get from the mini pterional approach. The opening is about 2.5 centimeters. This is what the incision looks at, like at 2 weeks post-op. Heals very beautifully. So by thinking fourth dimensionally, what I mean is I want us to consider what happens over time with a particular aneurysm. This patient was a 20-year-old male who presented with grade 2 subarachnoid hemorrhage, secondary to this dissecting ruptured P2 aneurysm. And you can see here that the posterior temporal artery, as well as the main trunk of the P2P segment of the PCA, arise from the dome of the aneurysm. And so this is a young patient, actually happens to be a family member of one of my partners, and I elected to treat him endovascularly up front with a flow diverting technique with adjunctive coil embolization. So we deployed a small flow diverter across this aneurysm. We undercoiled the dome of the aneurysm while still allowing some flow through the posterior temporal artery. Okay. By 7 weeks later, you can see that the aneurysm is completely occluded. I haven't fully shown it to you here, but the posterior temporal artery territory has now filled retrograde via PLPL collaterals because we let it shut down slowly. And so I felt very happy with this result. This should be a long-term permanent occlusion. We bridged the entire aneurysmal segment, but we brought him back for a 6-month follow-up angiogram, and we can see that the aneurysm has developed both severe in-stent stenosis, the inflow to the flow diverting segment, as well as this de novo fusiform segment distal to the prior aneurysm. And so now, as this aneurysm has evolved over time, we have to take a very different approach. So in this case, we've now decided to proceed with a distal trapping procedure. So we've clip occluded the distal PCA, resupplied that territory via radial artery bypass graft from the V3 segment of the vertebral artery to the P4 segment of the PCA. And that allowed the aneurysmal segment to then retrograde thrombose back to the P1 segment. And the patient did beautifully through this operation and now has a long-term permanent occlusion. Okay, now this operation will be much more difficult to achieve safely in the ruptured setting, particularly because getting both proximal and distal control is really two separate approaches. In this patient, you have to get all the way around to the P1 segment from anteriorly, and the outflow that you would need to bypass to in the P3 segment requires a very posterior approach from a subtemporal approach. And your degree of proximal control there, at least initially, is fairly poor. Now, again, doable up front, but in this case, we were able to achieve a very good result in the ruptured setting and then come back definitively later on to deal with that aneurysm. Very similar situation. This is a 33-year-old who presented with a Hunt Hess 3 grade subarachnoid hemorrhage. He has a history of a prior gunshot wound to the neck with complete occlusion of the right ICA, and it presented with rupture from this small aneurysm from the distal segment of the posterior communicating artery. Now, because the entire right hemisphere was being supplied from this posterior communicating artery, we elected initially to proceed with a stent-assisted coiling technique. So you see here that our stent has landed into the PCOM itself. At the time of the initial treatment, I've achieved a Raymond 2 occlusion. I've just got a very tiny amount of neck distally, but he's fully heparinized, has been given integralin, and we hope that this would go on to resolve itself. Now, he did very well from his initial rupture event, but he came back 3 months later with new subarachnoid hemorrhage, and we can see that this remnant has actually recurred just slightly. Now, I was able to get a microcatheter here, but getting coils to sit in that space without occluding this critical PCOM ended up being impossible. And so at that point, we then took the opportunity to solve the core problem, which is the sump effect into the ICA via the PCOM because of the chronic carotid occlusion. So We also attempted stent open the chronically occluded right carotid with the intention of flow diverting across the PCA. And what I haven't shown you here is that he has a very low-lying carotid basilar apex bifurcation, which is part of why we didn't approach this aneurysm microsurgically initially. But in this case, what we did was took him to the operating room. We created an STA to ophthalmic segment ICA bypass, and then trapped the PCOM after we've restored flow to the ICA. In this case, we were able to do it because he has an incredibly large STA, and then we've clip trapped across the aneurysmal segment, which now allows us the ability to completely occlude the aneurysm. So this next case I'm going to show you gets to the heart of what I think is really critical about comprehensive approaches. So this patient was originally a subarachnoid hemorrhage in 2019, 62-year-old at the time, who had initially had this ruptured basilar apex aneurysm coiled, had 3 subsequent retreatments, which ultimately included a stent-assisted coiling technique. And again, this was another aneurysm that was driven by increased demand across the PCOM artery because of a chronic right ICA occlusion. Here we can see that the PCOM is really supplying the entirety of the right ICA territory. And so this patient then presented to me several years later after multiple retreatments with this large, partially thrombotic, multiply coiled aneurysm. And you can see from the CTA at the right panel here that this aneurysm has been driven up into the third ventricle, incredibly high riding basilar apex bifurcation. So I would tell you that in my hands, this is a patient that does not have really clean-cut or really clear-cut microsurgical or endovascular options. So from a pure microsurgical approach, this is a non-clippable aneurysm, in my opinion. This is the kind of thing that we used to do cardiac standstill operations for, but I don't think there's a sane operation to try and clip reconstruct that aneurysm in a reasonable way. The other option would be to revascularize the basilar apex and then proximally occlude the basilar artery below the SCAs. And while that may diminish flow across the aneurysm and potentially stabilize it, is at best a palliative type procedure. Same thing for endovascular treatment. The patient's obviously been stent coiled initially with a single stent extending into the right PCA. The option of adding an additional stent and trying to recoil, but we know that this aneurysm has an incredibly high recurrence rate. Intrasaccular devices in theory would be an option, but are not likely to fit the morphology of that aneurysm and achieve achieve significant apposition to the aneurysmal walls. And flow diversion in isolation is not going to be safe or effective because it requires either for us to jail the entire left PCA or jail the entirety of the right hemisphere. So taking a comprehensive approach by doing first a microsurgical operation to set up flow diversion, we can potentially cure this aneurysm. So we consider this patient for a 2-stage treatment where we did a 2-piece OZ approach for creation of a high flow extracranial intracranial bypass from the common carotid artery to the MCA. And then we clip occluded the P1 PCA. The plan here being that we could convert the aneurysm into a sidewall aneurysm and effectively reverse flow through the PCOM, now allowing it to be fed by the bypass. And then we plan to bring the patient back in a couple of weeks, start them on dual antiplatelet therapy, and then flow divert the aneurysm with adjunctive coil embolization. So here we can see just a hint of the coil mass, but really can't get to the aneurysm in its entirety. We're plugging in the bypass, first the intracranial bypass, and then the extracranial portion. So if we pause here, we can see that the bypass is now backfilling the MCA, and then we can see the PCOM flow has reversed as opposed to coming through the PCOM and filling the MCA territory. It's now flowing the opposite direction. And as we clip occlude the P1 coming out of the aneurysm, we then make that configuration permanent. And this is what it looks like immediately post-op. So we can see the high flow bypass from extracranial, intracranial is refluxing all the way back down to the proximal cavernous segment. And then the 3D image here at the right shows the clip at the origin of the P1 segment. We've left a small antrum to allow the right SCA to continue to fill. And then this is now what we have. We've converted this successfully into a sidewall aneurysm. So we then brought the patient back a couple of weeks later. We deployed the flow diverting stent through the existing Atlas stent. You can see that as it passes through the interstices in this inset panel in the upper left, that there's a high-grade stenosis that we ended up having to balloon angioplasty. So we added additional coils. This is what the flow diverter looks like at the end of that procedure. And you can see we've undercoiled this aneurysm again to prevent occlusion of the right SCA. But when we come back at 6 months, we can see that the aneurysm is completely gone. The SCA remains open, but we have completely excluded the aneurysm. By virtue of the nature of flow diversion, we will consider this patient to be surgically cured, likely for the rest of her life. Now, this is her at the time of discharge following her flow diverter. You can see that she's got a third nerve palsy. That's an extensive amount of manipulation in this area. It ended up resolving several weeks later, but it is a morbid approach up front. So this is not something we reach for every aneurysm, but with this incurable aneurysm that we've now been able to cure, the risk profile is worth it. Now, I'm going to show you lastly here an aneurysm we treated from a purely microsurgical fashion, but I want to challenge the audience that I think there are ways of combining these tools that we haven't really thought of yet and that could potentially make these operations safer. This was a 32-year-old female who presented to me with new onset seizures. Was actually found to have a small amount of occult subarachnoid hemorrhage that this aneurysm had actually ruptured, precipitating the seizures. And this is a serpentine aneurysm that uniquely has two outflows. Here we can see one M3 coming out this way and another coming out this way, but a true serpentine morphology. And so, as with all serpentine aneurysms, these can be very effectively treated by bypassing the aneurysm and then either clip occluding the distal or proximal flow to allow the aneurysm to thrombose. So in this case, we made use of the so-called tandem technique, where we take a single limb of STA and supply both inflow and outflow. Here we're temporarily occluding the inflow and making use of flash fluorescence technique. So here we're seeing the two branches that are that remain unopacified by ICG. As we take the clip off, we can then flash fluorescence through them. And so now we're doing a side-to-side anastomosis with one limb of the STA and then an end-to-end on the same branch, and then permanently clip occlude the aneurysm inflow. And so here we can see the STA coming in from proximally, side-to-side anastomosis with the more proximal outflow. And then the branch continues on to the more distal outflow. So a single donor artery supplying both outflows in continuity in a tandem configuration. This is the so-called 1D, 2R bypass. Terminology I don't really care for because I think it limits our concepts of how this construct can be put to use. And this aneurysm is completely cured. So here on the postoperative angiogram, we see the side-to-side and then end-to-side anastomoses. The aneurysm is completely gone. The patient did beautifully. So I'm happy with this result. But this ended up being a long sylvian fissure split, and we have to prune a couple of veins in order to fully mobilize that segment, which we prefer not to do, especially on the left side. And I think there's actually a simpler way of doing this. So, we don't have a hybrid room at the University of Pittsburgh, but I would say that if I had access to that, my vision would be to place a microcatheter into the parent M2, deliver ICG directly through the microcatheter so that I can fluoresce both of the outflows directly, plug in the bypass, and then use coils to occlude the inflow right at the neck and be able to skip the fissure split in its entirety. So I think there's a lot of ways in which the comprehensive mindset can push the envelope in terms of what we're able to or what we're willing to consider doing endovascularly in ways that we would never consider without the benefit of the microsurgical tool set and the understanding of the limitations of both subfields. So in conclusion, I think this generation of neurosurgeons is uniquely positioned to deploy all of these tools all at once in combination and to practice in a way that I would consider truly comprehensive. And in that way, I think that that practice can become very complementary. So my microsurgical toolkit allows me to take advantage of that when it's the best and safest thing to do, but also to avoid its challenges. And same thing in reverse with the endovascular side. But we can also combine them together to create new solutions. And these combined approaches can simplify complex problems, either by breaking it up into two smaller operations or creating entirely new solutions that either subfield alone couldn't achieve. So that's the end of my talk. Again, very delighted to be here. And again, I would encourage everybody, regardless of their background in microsurgery, but ideally, or regardless of the background in neurosurgery, but if they're going to treat cerebrovascular disease, understand all of these tools, have access to all of them, whether in combination as a team or as a single surgeon, and then pick the right one, do the right thing for the patient.
Thank you, Dr. Lang. Thank you for a very nice presentation. Now I'd like to ask the panelists regarding for their views on the talk.
Hey, Arthur, do you have anything to say, Arthur?
Yes, sorry for the background noises. It's excellent, and I think Professor's message is very clear. Super selectivity, complete understanding of flow dynamics, and precision practice.
Thank you, Arthur.
Dr. Kishore Chaudhary would like to hear from you.
Yeah, sure. Michael, that was a very nice and very comprehensive talk, giving an overall idea of how to manage jointly. And actually, it's enlightening to see. I'm a surgical aneurysm surgeon, so I don't do endovascular treatment. And we have a huge volume of subarachnoid hemorrhage, 150 aneurysms, subarachnoid hemorrhage patients per year, managed between two of us. So you're talking about one or two per week, and we get about 400 AVMs and about 400 unruptured incidental aneurysm per year. So huge volumes. So we don't really have time, energy, resources to treat unruptured aneurysms. Most of us, our practice is 99% subarachnoid hemorrhage related. But your talk is really, even for me, who have been in vascular neurosurgery for 25, 30 years, it's been very enlightening. And this is something the newer generation has to pick up, understand the flow dynamics, understand and accept and adapt to the newly developed techniques very rapidly, because it's such an evolving technique, especially endovascular field. And unless you're on top of it, the quality of results and the quality of cases that you have shown, these are going to be very difficult to replicate for everyone, unless number one, they have the open mindset to adapt to the changing conditions, and number two, they have the volume of cases, the case mix, and the setup to provide that. But you have obviously shown to the younger generation that, look, this can be done, and the overall results are quite good, and even better than what we would have treated by open surgery. Because some of the aneurysms you have seen, I was thinking in my mind, they are potentially untreatable. But your magical treatment, combined treatment, and a comprehensive approach, I think you have proven me wrong, and my beliefs are a bit shattered that look, these aneurysms can be treated. Otherwise, I would be saying that, look, this is an untreated aneurysm, neck recurrence at basilar aneurysm, so be it. As long as it doesn't rupture, we'll just follow it up. And yeah, that's true. But thank you very much. That was very enlightening talk. Enjoyed it completely, and I hope that our younger generation takes a leaf out of your practice and adapt in their practices.
Thank you both so much for the comments. Very, very kind words. And again, this is one of my very favorite topics to talk about. And I think it is one of the things that we've been uniquely privileged to be able to consider doing in North America. But I think for a large chunk of Europe, for example, microsurgery has largely disappeared, and I think that is not an appropriate approach either. And so I think for surgeons all over the world in places that are able to embrace dual training, I think that is very much the right way forward. At least that's something I feel very passionate about. So thank you again for the kind words, and thank you guys for having me join. I really appreciate it.
My only one comment and the concern is, especially in Japan, I've seen a number of times the threshold for offering treatment for unruptured aneurysms is quite low in many practices. Sometimes it is just driven by culture. Sometimes it is financially motivated. Surgeons or operators have their own financial interest, and so do the hospitals. We don't have that, neither of them. So I believe that many of the recurrent aneurysms that you've shown after coiling, or we do get recurrence, we tend to follow them forever. And you'll be surprised. The aim of the treatment is not to obliterate the aneurysm completely. The aim of the treatment is to prevent subarachnoid hemorrhage. And many a times, subtotally or partially occluded aneurysms, especially in poor grades, they don't grow, they don't bleed, and patients remain intact for a number of years. And because we are a closed community in England, in our region, our patients are not lost to follow up because they have nowhere else to go. They cannot go from one region to another, they are sent back to us. So we have almost 100% follow up. And I've been now following up coiled aneurysms since I participated in ISAT trial in 2002. I've been following up number of aneurysms for a huge number of years, of 20, 25 years. And you'll be surprised that the risk of rupture from partially coiled or recurrent aneurysm is extremely low. So my word of caution would be to be more circumspect when you're offering treatment for the aneurysms that appear to be recurrent but otherwise stable. That would be just my general comment.
Yeah, I think that's an incredibly thoughtful comment, and I hope it comes across that the couple of recurrent aneurysms I've shown here are either giant in size. There are a couple that have, a couple of the PCOMs that I showed that have really de novo irregularities forming at the base of the aneurysm that are completely unprotected by the coil mass. And both of those patients were heavy cigarette smokers, so high risk patients. But to your point, I cannot agree more that we do not need to treat every small neck recurrence. We certainly don't need to be treating every aneurysm that we see. And the same thing in North America. It's not uncommon for us to see people getting flow diversion treatments for 3 millimeter cavernous aneurysms that have no business being treated. And that's where, the beginning and end of every talk I try to give is that we have to put the patient first. What is the natural history of this problem? Obviously we have a number of grading scales to help us guide which patients need to be treated and which not when we encounter unruptured aneurysms. But that comment could not be more sage advice. We absolutely need to consider not just the angiographic picture, but the patient's outcome first and foremost.
One more question to you, Michael, about your presentation and experience. That in the setups where in India there are a number of smaller setup, and not all patients go to the university hospitals as you would go in Pittsburgh or with us in Sheffield. Uh, how do you envisage that surgeons who have got a relatively lower volume of subarachnoid patients, typically average about 10, 15 a year, or maybe 20 a year, how do they develop and maintain their skills in both the approaches? Because this is a multifactorial problem. And unless you're good at both of them, you could be actually bad at both of them either, because there's a learning curve for both the procedures, and it's
Yeah.
completely different.
Yes, absolutely. I think we have very good evidence that that all of cerebrovascular surgery, but aneurysm surgery uniquely, benefits from being performed in high volume centers. We encounter similar problems in the United States where patients are treated at centers that treat 5, maybe 10 aneurysms a year. And that's probably not the most appropriate thing for the patient if it's feasible. Obviously, in countries where travel distances are quite long, or there are cost limitations to travel to more comprehensive centers, that's a very different issue. But it's very different than when we talk about mechanical thrombectomy and stroke, in which we need to deploy those technologies rapidly and quickly where the patient is presenting, as opposed to patients with ruptured aneurysms. I think number one, we try to get them to high volume centers, and number two, I think the benefit of the world that we live in is that we have I'm on the other side of the world talking with you all right now. I think it's always worthwhile to go and visit other surgeons and learn new tools and techniques. So I think the kind of classic teaching in medicine of go where the experts are and spend time with them and learn. Time in the lab, both endovascularly and in the cadaver lab microsurgically, can really advance these toolkits. And I think kind of building up to more complicated solutions is what is necessary. So in the world of bypass surgery, for example, starting out with simple ST8M4 bypasses, advancing on through A3 or pica side to side bypasses, and later to the PCA or more complex constructs beyond that. But it can't just all be done at once. And sometimes it's important to remember that the safest tool is the safest one in your own hands, right? So reaching for something that might be theoretically possible, but you're not quite equipped for, is probably not the best thing to do for the patient. So I think that always remains important. But knowing that these solutions exist out there, allow people to reach for them when it is the right thing to do.
Okay, yeah, we hope to provide the central channel, Michael, for dual neurosurgery education. And we appreciate your talk, and thank you very much for getting up so damn early in bed.
Thank you so much. I appreciate it. I'm going to head off to bed now, if that's okay, guys.
Okay,
Have a nice
thank
day.
Thank you.
Okay, back
Thank you,
to you.
Dr. Lang. for the talk.
Back to you, Divya.
Okay. Okay. Thank you, Dr. Lang. Now moving on to our next speaker, Dr. Girish Rajpal is the Director of Neurosciences at Max Super Speciality Hospital, Vaishali, Delhi. And he's a globally trained neurosurgeon, skilled in both open and minimally invasive neurovascular procedures. He graduated from AIMS Delhi, completed his fellowships from France and Switzerland. His expertise includes brain aneurysms, AVMs, stroke, spinal disorders, and pediatric neurosurgery. He is widely published, actively involved in leading international neurosurgical societies as a clinician, researcher, and a leader. We welcome you, Dr. Girish Rajpal. The screen is yours now.
Thank you, Divya. It's no nice introduction for me. I'm going to share my screen. Are you able to see?
No, you're not sharing the screen yet. You got to share the screen.
Just hold on.
Yeah, click the share button. That's the first thing you should check. There you go.
Yeah,
You're on your way.
yeah.
And
So now you're able to see?
presentation mode, please. Yeah.
Yeah,
Perfect.
it's okay?
Yes, perfect.
Okay. So this presentation is basically for the young neurosurgeons who are going to do endovascular neurosurgery or just started doing endovascular neurosurgery. So it's a basic talk about how to choose the hardwares. So in endovascular neurosurgery, let's divide it into two parts: cerebral DSA, the basic one, and therapeutic procedures. So first we'll go to the cerebral DSA, how to choose the hardwares. The basic cerebral DSA, we only need 3 or 4 at the most hardwares. And the first one is sheath, femoral sheath, if you are going to do it from the femoral puncture, or radial sheath, if you are going to do it from the radial puncture. So sheaths have different French, but for the diagnostic purpose, we are going to take 5 French femoral sheath or 5 French radial sheath. Followed by that, we need a diagnostic catheters which have different shapes, and according to the shapes, they are named accordingly. So the most common diagnostic catheters which we choose in our practice are Picard, Wert, and H1. So in between 3 diagnostic catheters, you can choose any one of them and practice your endovascular DSAs on these 3 diagnostic catheters. These are the shapes which you can see on the left side. The angles of the distal end of the diagnostic catheter are named accordingly. So the arrow which is I'm mentioning this is the word. This is H1. The right angle will be the Picard, and this is SIM1 and SIM2 accordingly. Followed by, then you have to choose the diagnostic wires. we choose 0.035 or 038 wires with J-tip. We don't use the straight tip wires because they can cause dissection and cause entanglement in the branches. So it's better to choose the angled wire, which is J-tip wire of the size 035 and 038. Most of the wires are hydrophilic and most of the wires are with the name of Terumo wires. Coming to the therapeutic one, which is the difficult one for the young neurosurgeons, I divided for the simplicity it into the three parts. One is we need the hardware for stability, then we need the hardware for the navigability, and then we need the hardware for delivering the target things. So the simplest of this is biaxial system, which means that stability and navigability will be combined in a single guide catheter. And the little bit complex is the triaxial system, where stability will be tackled by different catheters, navigability by the different catheters, and delivery by the separate of different catheters. So stability and navigability is equal to SS. So in biaxial system, our SS will be guide catheters. And in triaxial system, our SS will be long sheath followed by through with the distal SS catheters or intermediate catheters. Example, so if you can see, this is the right tortuous anatomy of the ICA. If we wanted to use the biaxial system, these are the catheters. The most common was 6 French envoy. Suppose we wanted to use the 6 French envoy in this tortuous ICA, we are not able to approach beyond this curve. So we have to place our guide catheter till carotid bulb only. And then from this, we have to go through microcatheter all up to the aneurysm, ACOM or MCA, whatever you think. Then the stability will not be good. It may fall down, the whole system will collapse into the parent vessel. So to tackle this problem, we have the triaxial system where we place the long sheath in till the carotid bulb. Example is like this. We place the long sheath till the carotid bulb. Then with the distal SS catheters, which are named according to the company choices like Navion, Envoy DA, CAT, Sophia, according to different company names. We place these distal SS catheter through long sheath, crossing this tortuous anatomy. You can go up to cavernous segment or till the bifurcation of the ICA also. And then you can deliver your microcatheters and other things also. So I hope till triaxial system, you are able to understand what is the difference between biaxial and triaxial system and which is the better among the tortuous anatomy of this thing. Coming to delivering, we have I divided this thing into two things, delivering catheters and target material. These two things are chosen according to the pathology of the brain or vascular system. Suppose the pathology is arteriovenous malformation, then our target is nidus. And similarly, if the pathology is aneurysms, then our target is aneurysm sac. Or if the pathology is stroke, then our target is occlusion site. And accordingly, we'll choose our delivery material. And accordingly, so AVM, arteriovenous malformation, target is nidus, material will be glue or liquid embolizing material agents. Similarly, for tumor, target is arteriocapillary beds, material will be PVA particles. Aneurysm, target is base of sac, material will be coils. Similarly, stroke, target material will be stent retriever or aspiration catheters. Example, so this is the AVM. You can see this is the AVM. Here we use the glue NBCA, N-butyl cyanoacrylate material, which you have to mix with the lipidiol. And this is the end result after glue injection. And what is the advantage and disadvantage of glue over liquid embolizing agent? You have less time to think and act, uncontrollable, and the catheter got stick if you are not able to retrieve the catheter timely. These are the disadvantages of the glue. And now this is one of the example of onyx, liquid embolizing material. You can see here the cast of onyx. You have a time to think and act. How much time to think and act? Just look at this. This is the time to think and act. Controllable, and there is a reflux. You can see here. And reflux of onyx may cause a catheter. You can see here that there is a reflux of the onyx in the microcatheter, which caused stickiness of the microcatheter, and microcatheter was all the way till the femoral and we are not able to detach it. So to tackle this problem, we are now having detachable microcatheter tips, and they are with the name of Sonic and Apollo. And here you can see this point here, the proximal dot. You can have a reflex of liquid embolizing material till here, and you can still safely detach the catheter from here. And they have come into two sizes, 1.5 centimeter and 3 centimeter. Means from proximal to distal end, you have 1.5 centimeter detachmental tip, or proximal to distal end, you have 3 centimeter of detachment tip. You can see here the detachment point here. And there are other liquid embolizing material also, like Sequid, Fill, EasyX, which all have different advantages and disadvantages over the onyx. Like squid have tantalum grain size smaller, less sedimentation, and more homogeneity. So you have not continuously going to shake, unlike the squid, where you have continuously shake the squid onyx. Fill, which is iodine covalently bonded, making it radiopaque virtually with no sedimentation, and EasyX with no artifacts on the CT, unlike the liquid embolizing agents, which have a lot of artifacts on post-op CT. Coming to aneurysms. So I'll come to, yes, aneurysms. I'll come straight to the, okay, here. So aneurysm, you have the multiple problems with the aneurysms. The one which is the most common problem previously when the ISET trial was there was the stretchable coils. The coil becomes stretchable while deploying, and it will got deployed in the parent vessel. To tackle this problem, now all the coils are almost stretch resistance, meaning when you deploy the coil, it will remain in the aneurysm sac and will not stretch out in the parent vessel. Coming to balloons, there are balloons, multiple balloons of different sizes and shapes accordingly, like hyperglide, hyperform, transform, scepter, ascent. But broadly, we divide the balloons into two variations. One is compliant and the other is extra compliant balloons. Extra compliant balloons like hyperform will be used in the bifurcation aneurysms. Like in this case, we use this hyperform balloon in the basilar artery bifurcation aneurysm, or hyperglide balloon, which are compliant balloons, which will be used for side wall aneurysms. Like this, in this case, this is a side wall aneurysm. This is the hyperglide balloon, inflated, coils deployed, deflated the balloon, and the coil stays in the parent vessel. Then comes the wide neck aneurysms, which will be tackled only by stent-assisted coiling. And there are various available stents available with different vendors, right from Solitaire, Enterprise, Neuroform, Atlas, Leo, Elvis Jr. is to tackle the problems. Like if you are going to use the Atlas Neuroform, then the single microcatheter, because it's a low profile stent, so single microcatheter, you can deploy the stent, and with the same microcatheter, you can coil the aneurysm. But suppose you want to use the Enterprise or Solitaire, then you have to choose two microcatheters, one for the aneurysm, which will be 17 catheter, and one for the stent, which will be 21, a little bit large bore microcatheter. And you have to place the large bore microcatheter in the parent vessel, and simultaneously you have to place the other small bore microcatheter in the aneurysm. and then you deploy the stent first and do the coiling later on. This is the dual thing. So this is the example of solitaire. The problem with the aneurysm was there were chances of compaction and regrowth causing recurrence of aneurysms. So to tackle this problem, multiple companies do a modification of the coils from the hydro coils to the different types of coils, which come with the name of Presidio, Microsphere, Axiom Prime, Target Nano, which reduces the risk of compaction and also reduces the risk of regrowth, thereby causing less chances of recurrence. So these are some of the follow-up patients of wide neck basilar artery aneurysms and MC aneurysms, wide neck, which were treated without stent, or either with the balloon or along with the coils. And this is a 1 and 2 year follow-up showing virtually no recurrence of aneurysms. Similarly, this is the ACOM aneurysm, wide neck, treated without any assistant, only with the coils. Another example. Then comes the flow diverter. Flow diverter thing is based on simple principle that once you disrupt the inflow and outflow jet into the aneurysm, and which causes endosaccular flow stagnation, which further causes flow direction modification and maintaining the perfusion and patency of the perforators, decreasing the shear stress, causing endothelization of the parent vessel, thereby excluding the aneurysm later on gradually, which itself causes thrombose. So these are different types of flow diverter devices available in India, at least: pipeline embolizing device, Silk, Fred, Surpass, P64, etc. So it virtually acts as an endo clip, unlike the neurosurgical clip, which is in the subarachnoid space. Let's call it an exoclip. This is one of the example of flow diverter device. You can see here the large aneurysm, and this is the follow-up 3D reconstruction after 6 months. You can see it looks like there was no aneurysm before, and because the whole of the vessel is endothelized with the flow diverter device. Another example, cavernous segment aneurysm. This is MR angio after 1 year. Another example, a blister aneurysm here. No option in endovascular except to put the flow diverter here, and this is follow-up. Another example, a fusiform saccular aneurysm here, and this is 6 months follow-up, gradually thrombosing. Another examples, you can see here the example, whole of the basilar system is aneurysm. We have to put 3 flow diverters here, and this is follow-up after 6 months. This is, you can see a large aneurysm here, and this is gradually shrinking. This is one of the advantage of flow diverter, that the flow diverter causes decreased mass effect also. Unlike the coils, if you put the multiple coils here, the mass effect will remain persistent here. Let's see the example. Different types of examples here. Flow diverter with coils, flow diverter without coils. You have to. Now I'll discuss how to choose the flow diverter. Two most common flow diverters in India are Silk and Pipeline. This is the advantage and disadvantage over Silk and Pipeline. Silk has a low radial force, unlike the Pipeline device, which has a high radial force, high resistance to narrowing of the stent ligament. Here you can see Silk can cause, because of the low radial force, there is the chances of stenosis at the curve point in the Silk. Unlike the Pipeline, you can see here at the tortuous point, because of the high radial force, the chances of narrowing or shrinking of the Pipeline is less as compared to Silk. Silk, unlike the Pipeline, is having a good visibility. You can see here that there is a very good visibility of the Silk device, and Pipeline, you have to see carefully that there is a device you have put here in the native image. Silk can be resheathed, removed, or repositioned up to 80% of the stent deployed. Pipeline, the first or second generation was almost 50-60% resheathable, but now the new pipeline Vantage, you can resheath till 80%. There are many lenses available. These are other devices like Fred is stent in stent. It's almost two stents, one stent inside the stent. So I don't think it's a good device for flow diversion. Surpass has long lens up to 60 centimeter. Only available flow diverter before. Now many companies are developing 60 centimeter devices in the length. P64 has the advantage of fully retrieval. You can redeploy it if you do not like that the position of the P64 is not good. Even after 100% deployment, you can still redeploy it after resheathing it inside the microcatheter. This is intrasecular device. One of the intrasecular devices, web, balloon-assisted coiling or stent-assisted coiling to to prevent the dual antiplatelets. Then you have to deploy this intrasecular device where you can see here the post-op web without any recurrence. Another device is Piconus. I don't think it is available now anymore in India, but this is one of the example here. Instead of web, you put the Piconus device, and then through this device, you can coil the aneurysm. So it acts as a aneurysm bridge device. Coming to the stroke, these are all the devices which are no more available today. What I'll discuss is two devices which are available. One is Solitaire and another is aspiration devices. So this is stent retriever. Solitaire previously was used as a aneurysm, you can say stent assisted coiling, but now its main use is as a stent retriever to retrieve the clot from the occlusion site. This is one of the example. You can see here the middle cerebral artery occluded. You deploy this device Solitaire inside the occlusion site and remove the clot along with this device, which is known as Solitaire or stent retriever as a generic term. This is the aspiration catheters from the penumbra. You can see here the aspiration pump. Unlike the stent retriever, where you have to cross the clot all through the blind spot and go distal to the clot and deploy the stent retriever, in aspiration system, for the young neurosurgeons who are hesitant to cross the clot blindly, in aspiration system, you just have to place the aspiration microcatheter proximal to the clot and suck this clot with aspiration pump. This is another example of middle cerebral artery. It has a trifurcation. One of the superior trunk of the middle cerebral artery is occluded, and this is reperfusion of the superior trunk after removing the clot. So there are different types of stent retriever also, like Revive, Trevo, Eric, Preset, Solitaire 2, now 3, now X, and multiple, depending on how good is the radial force, what is the visibility of the stent retriever device. You can choose among these 5 or 6 sets of options available for you. To retrieve that. If you have a hammer, it does not mean that you need to put a nail in the wall every time. As Dr. Michael Lang already said, that we have to approach the patient as a patient first rather than the microvascular or endovascular first approach. Thank you.
Thank you. Thank you, Girish Raspal sir, for an excellent overview of all the hardwares. One thing I would like to ask, is there any difference between the anticoagulant protocol that you use for stent compared to the flow diverters?
Yeah,
Since
flow
flow diverters have a higher metal load.
Yeah. In the stent, we usually use only the clopidogrel or ecosprin as a protocol. But for flow diverter, because in India at least, most of the patients are clopidogrel resistant. So instead of clopidogrel, we use ticagrelor. So it's Brilinta and ecosprin instead of clopidogrel.
Okay. Okay. Any comments from the panelists?
Sorry, excellent presentation, Dr. Rajpal, and very informative as well.
Thank you,
And
sir.
it is so good for the younger people who are just thinking about taking up endovascular specialty. It is so important to listen to it. I hope Divya, that this webinar is recorded so that if someone has to go back to Dr. Rajpal's speak, they can refer to it and then listen, because it's a lot of information to take in a short period of time. So probably another presentation like this would be very welcome as well, again in a few weeks' time, Dr. Rajpal. But it was so clear, so good, and such informative. I've got a couple of questions for you though. That
Yes,
I
sir.
believe you practice in Delhi, is that correct? Max hospitals are
Yeah.
in Delhi. Is that right? Yeah.
Yeah.
So
Yes.
in Delhi or in any other central institutes in India or any other places, I have been to Delhi only once, so I don't know. But are there any centers which provide endovascular training? I'm not saying supervision, training, hands-on training with good numbers in your area. And this is for not only the radiologist, for neurosurgeons as well. Are there any centers that provide kind of fellowship training with numbers, hands-on?
Ac- Actually, slides of my fellowship and training. So, but in a hurry, I forget to include one came from Nepal, just completed their fellowship last year. And we have a hands-on training. Divya, where he was before GB Pant, they also have the training, hands-on training. And in between, we have some simulator calls also, like you can say 3 or 4 times a year in our center, where you can come for a short visit also.
Sorry, it's breaking up. I don't know whether it's at my end or
For a week or 2 weeks and have a I think it's on my end. So what I'm saying, it was my mistake. They were told me to include the slides of fellowship programs in our center, but I forgot to include those slides. So we have the fellowship program, hands-on training program. Uh, Last year, just two fellows from Nepal came and completed their fellowship.
Okay, Atabati, do you have a question or comment, Ata? Go ahead,
Yeah,
Ata.
yeah, excellent presentation and review, very detailed, Dr. Girish. And yeah,
Thank you.
thank you so much. And we look forward for further sessions by you, going into more details. I just want to have, I want to just share that these tools are ever changing. So the main thing is principle. So, I mean, we should know about the tools, but the principles are the main thing during the training. And as Dr. Michael also mentioned, the precise knowledge of flow dynamics is what we look for in our practice. And it's obviously not endovascular versus microsurgery. It's us versus aneurysm or disease. So I think the teamwork should focus on better workflow. So unfortunately, many of our energies are wasted dealing with the other issues, which which the higher income countries, developed countries, has settled 3 decades back. So we are still into who will do it, who will not. So we should move forward to a new level. Whoever is uh, is sound for patients, his practice will prevail, and the work will itself results will itself announce who is doing better. Another comment I would like to make is that you mentioned, Dr. I think Professor Kishore mentioned that most of the time we deal the ruptured aneurysms. So the bulk is so high, the numbers are very high. So treating people are still very low. The moment we train another person, the population grows disproportionately, and I think this is where we should remember that these are the difficult cases. The ruptured ones are the difficult cases. The emergency ones are the difficult. So anything you do after 4 weeks, the storm already has settled down. So there is less reactive vessels. So you have a more friendly operating environment, less swelling of brain, and so these are the most difficult cases the people do. And even we see the Yashir Gill's Professor Yashir Gill's series. Any grade containing E has a worse outcome than the non-emergency. And for our part of the world, yes, a lot of financial issues are there. So the mechanisms to pay the health expenses are very typically a major problem for patient, and it's usually the self care process for patient and family. So naturally, these things are the major barrier for the growth of the field. And at times, the availability of tools. So we work with the limited choices. Many times we work without having an aspiration catheter on our inventory, and people cannot understand who are working in the well-developed centers that what amount of stress we go through, and it's very easy to burn out. And this was the reason why people were not much interested in neurovascular in the past. And in last decade, now a lot of people are coming into the field, but still we have to, as a dual neurosurgeons, we face a lot of challenges. And I think we support the neurosurgical history and clinical basis of dealing with the neurovascular. So we should be complementary to all who are doing the good quality work, especially to our younger neurosurgeons. And this is something which is the main purpose of coming up with dual neurosurgery forum. Thank you so much, Professor Kishore, Professor Girish, and Dr. Arun Kumar, Jeremy, Niranjana, and thank you, Divya, for having this session materialized. Thank you so much.
Okay,
Thank
thank you. Moving on to our last segment, the vascular board. Today we have with us Dr. Arun Kumar Sekar, another young and passionate hybrid cerebrovascular surgeon. He's currently the associate professor in the Department of Neurosurgery at AIIMS, Bhubaneswar, India. He obtained his formal neurosurgical training from NIMHANS, then went on for fellowship training in endovascular, skull-based, and pediatric neurosurgery. He has been instrumental in establishing the endovascular neurosurgery services at AIIMS, Bhubaneswar. He also runs a fellowship program in endovascular neurosurgery. He shall take us through some of his interesting cases. Over to you, Dr. Arun Kumar.
Thank you, Divya, for the very generous and kind introduction. So before, without wasting time, I'll quickly go on and present my case. Why do we need dual training? Why do we need both endovascular as well as open surgical skill set in our armamentarium. So are my slides visible?
Yes, we can see.
Yeah. Yeah, so first case, we have a 20-year-old gentleman. When we had seen the Venn diagram given by Dr. Lang, where there is a mix of both. There are some cases which can be endovascular, some cases which can be open microsurgical. So this is one case, low-grade AVMs. We have all come across these kind of AVM, deep-seated low-grade AVMs. I guess it is easy for both endovascular as well as microsurgical, and I'll just show you what. We have done. This is the anterior circulation AVM from the feeders from the pericolosal with a single draining vein to the superior sagittal sinus. We decided that we should tackle this with a craniotomy. The main reason for this decision making was financial. This could have been done endovascular also. So this is, you can see the arterialized draining vein, and like for all deep-seated AVMs, you follow the vein to small deep-seated AVMs, you follow the vein to reach the nidus, and this is what we had also done. We followed the vein, reached the nidus, dissected all around the nidus, had a proximal control, then circumdissecting around the AVM nidus, and all the feeders were taken out, and finally the draining vein was identified, cauterized, and you can see the vein, the arterialized vein becoming a normal venous structure post resection, checked with this thing, and that is how the nidus looks. Checked with an intraop imaging like a ICG, and that is how the nidus looks. This is one option. The second option is you can see a posterior circulation AVM on a very young child who presented with a sudden onset ataxia, and CT imaging showed a middle cerebellar peduncle bleed with a very small nidus. So this we had treated with endovascular route. So that's where you can see, if you can see, that is where the nidus is. So it's a very small nidus. So we had embolized this using an endovascular route. So we have options for both open and as well as microsurgical clipping for a low-grade aneurysm. But how about high-grade aneurysm? If it is a multi-compartmental aneurysm located something like this, so we have this young gentleman with a 59-year-old gentleman presenting with multiple episodes of sensory phenomena. It is mostly more like a sensory cortex seizures. He had a significantly larger AVM with drainage. I'll just show you the circulation. He has multiple feeders, both from the posterior circulation as well as from the anterior circulation. And you can see there is an aneurysmal dilatation of one of the posterior circulation feeders. So, and he had a very unique problem. We wanted to offer him endovascular treatment, but he had very limited finances. And this is a very common scenario we all face. We get all the microcatheters. You have money, you have everything available in India. But what about people who are not this side, not that side, and want to have the best possible outcome? For this patient, we had decided, okay, fine, let's stage the procedure. We can take down the aneurysmal dilatation from the feeder from the posterior circulation, and we can tackle the MCA surgically. So this is how we had decided and went ahead with this patient. So this is one more view of this. He has both MCA feeders and the posterior PCA feeders, and there is an aneurysmal dilatation of one of the feeders from the PCA. And he underwent partial embolization of feeders from the PCA. So that's the intraop imaging. Posterior circulation run, and this is the anterior circulation run, the MCA feeder. This is pre-embolization. So we took down multiple branches of posterior circulation. You can see the deep draining vein going into the deep venous system. So we had taken down all the posterior circulation feeders, and these are the feeders from the MCA that are remaining. So we decided, this is the intraop picture. So when we decided to resect the remaining, and went ahead with a surgical resection in a second stage. So identified all the traced all the MCA feeding arteries, went around the aneurysm, I'm just running it forward so that we don't, it's a little longer video. You can see the glue cast in all the embolized feeders. That's the aneurysmal dilatation that was embolized using the onyx. So that was resected out, and you go around the AVM, go towards the ventricle, and that's again one more view of the aneurysmal dilatation that we have embolized, and that's the draining vein. You can see the draining vein of this aneurysm deep going into the ventricle and going into the deep venous system, and we successfully could resect this AVM. And this was checked with an intraoperative imaging. And that's the nidus. So, and this is the post-op imaging. We are yet to do an intra-op, a check angio for him, but this is the CT angio done outside. So that is the options as a surgeon. As a surgeon, especially when we are working in a limited resource environment like ours, if you have both the skill set, if you have an endovascular skill set as well as an open microsurgical skill set, complex aneurysms like this can be easily managed by employing by combining both the tools. And this is for AVM, and this is another example of how we tackled with aneurysm of a very little rare kind of presentation, aneurysm extending into the cella. We had a lady, middle-aged lady, who presented with loss of vision on one eye. She had an aneurysm protruding from the anterior communicating artery complex down into the cella. You can see the aneurysm, bilobed aneurysm, with a little bit of cellular erosion. So we because the option was both clip reconstruction as well as endovascular flow diversion, but again money was an issue, and we are not sure about how exactly to relieve the pressure on the optic nerves. So we decided we'll go ahead and clip and decompress the aneurysm. So that is what we did, and she had made significantly good improvement. This is one way, and then there is a similar kind of case with aneurysm extending into the asymptomatic, just incidentally diagnosed aneurysm extending into the cella. You can see the aneurysm with a narrow neck and extending into the cella, partially thrombosed kind of an aneurysm. And we just went ahead and coiled this. So this is pre and post coiling imaging. This is pre. So a similar aneurysm presenting in a similar location, which can be managed either open or endovascular, and you can do this only if you have a clear understanding of the advantages of one over the other. What is your clinical outcome you're expecting? What are the cost concerns? And you should have all the things in your armamentarium. So what I am trying to put forward is, when I was looking at it as expert, if you are an expert, you should be able to give option A, option B, and option C, all options to a patient. You cannot say I can do only this, or this is only the best, or this is only the best. So instead of calling it as a hybrid neurosurgery or a dual neurosurgery, as a neurovascular surgeon, you can call yourself as an expert only if you are well versed with all the modalities of treatment. You should be able to give option A and option B. And if both these options are not viable because of some reason or other, you should be able to present another option, option C, where you can combine these two options. But do we really have that kind of an exposure in our training? So, I mean, I was just looking around the literature to see whether this is only uniquely our problem or anywhere else in the world this kind of an issue is happening. So when I went through, this is the very last month this has been published in Australian Medical Journal. So they went ahead and saw there were around 10 accredited fellowships in Australia, and there are 71 accredited neuroendovascular specialists, and almost 50 of them are radiologists, and only 9 of them are neurosurgeons, and all 9 of them were trained internationally. So what they see is okay. Has this changed anything in their practice in the volumes? So what they have seen is that the volume of cases that they do, it is not changed much. The aneurysms, the AVMs, and so the bypass cases, they are still the same. But aneurysm cases have not changed, but the number of cases that have been treated endovascularly are almost doubled, have almost doubled. So most of the aneurysm cases are taken out of the hand of a neurosurgeon, and I'll come to the point where why exactly I am telling you this. So many of the centers, even centers in UK, centers everywhere, there is an MDT, and the decision making is decision making seems to be okay when you put it in an MDT. But what they are saying is an MDT cannot be efficient if there is a significant imbalance of technical skill, understanding, or respect among two different totally different subset, like an endovascular a surgeon who does not know how endovascular works, or an endovascular guy who does not know the benefits of a surgical clipping. If you sit on an MDT, the decision making is always going to be lopsided, right? If probably your the person, senior most person is an endovascular guy, and he says this has to be this, or or there is a general understanding that okay, let's coil first for every aneurysm and then go for clipping if coils fails. This is how the decision making becomes lopsided, and we all have mentioned that while centralization and higher volumes help achieve better outcomes, the benefits is undermined without a robust and engaged surgical service. If you the outcome of an endovascular service is more in a center where there is a locally high microsurgical volume. Without any surgical high surgical volume, the outcome of endovascular outcome are also not that great. So we should be having, as I mean, we should look at ourselves as rather than being very dogmatic and say no, I'll only clip, or microsurgery is the best, or endovascular is the best. I think we should adapt a more comprehensive mindset and consider ourselves rather than thinking of hybrid or a dual. If you are going to be a neurovascular surgeon, if you're an expert in neurovascular, you should be having everything in your hand. You should be able to clip, you should be able to coil, and you should be able to give another option if the patient, if the situation demands. And that is how the step ahead has to go forward. So I mean, recently we attended one of the meetings where giants of endovascular were there. Jacques Moret was there. And he was like, there was a discussion, and then somewhere the topic came like, why can't we put an EVD? What is so great? Why do you have to wait for a neurosurgeon to put an EVD? And then next comes, okay, why not, if you are putting an EVD, why not do a mini craniotomy and evacuate the clot also? So counterintuitively, the argument was, why do you need a neurosurgeon? But counterintuitively, when you listen to the argument, they are, I mean, this is from the horse's mouth, Jacques Murray. So he is telling, counterintuitively, the argument says that to give the best outcome, you should be a neurosurgeon. It's not like yeah, radiologists are good, they are experts. Neurologists, they are good, they are experts. But if you are going to give a comprehensive outcome, best outcome, the counterintuitive argument is, if you know surgically to treat the complications also, that is when you can give a better outcome. So we should, in India, we should also, there is the same kind of a situation where Australia is right now. We are in India. We don't have specific areas where we can go and train in high volume centers. So the disruption has to be done at a little bigger level, like GB Pant has, and we also have in our very own small way. We have an endovascular neurosurgery, neuroendovascular surgery PDF. We do train. We are taking up our second batch of fellows for this fellowship course. We are a relatively smaller center, but I think this has to be taken up as a more national level. Disruptions has to come at bigger centers like AIIMS, Delhi, NIMANS. These kind of centers have to push forward and probably put in endovascular training as a mandatory thing in the curriculum. Like you should, like for example, you have to have 150 clippings. You see, same way there should be endovascular. Maybe probably you should do at least 100 diagnostics before your MCH. If this kind of integration happens, that is when I think this comprehensively this field develops rather than being completely disjointed and stuck at one sphere. So that is my 2 pence on this topic. Thank you for the opportunity, Dr. Divya and Econs.
Thank you, Dr. Sekhar. There was for your insights, and there were some interesting cases. I'd like to thank again all the speakers and the panelists. And any last comments from the panelists? before we
Oh,
wind up?
excellent webinar and lovely, very informative speakers, all three of them. The last speaker, Dr. Sekhar, was also very good. He gave a very good oversight of what's happening and how things should be. And I think very thoughtful comments as well. So congratulations to you guys for arranging such an excellent webinar.
I just want to mention that you can get copies of this video on our neurosurgical YouTube channel. I put the link in the chat if you want to see a copy of this webcast as well as the other ones we've done. Okay, onward, Divya.
Okay, thank you. Thank you, everyone. Until next month, we'll be meeting again with new speakers, new topics. Until then, thank you so much for joining. See you again
Yes.
the next month.
Yes, this is the dual neurosurgery channel, and we'll see you at least once a month, and you're all welcome to come here. We're going to try to do this every week with different collaborators to really get this channel going. So thank you, everybody.
Thank you. Thank you.
Thank you.